Imagine waking up from, like, a perfectly executed, totally life-saving surgery, only to realize the real trauma is actually just beginning.
Right, because the stitches are going to heal in a few weeks, but the financial devastation is a whole other story.
Exactly. I mean, the surprise bills, the out-of-network fees, the denied claims, that kind of thing could take decades to survive.
Yeah, the clinical problem is fixed in the operating room, but the financial machinery just breaks the patient the second they walk out the hospital doors.
Welcome to this deep dive. Today is Wednesday, June 3, 2026, and we are speaking specifically to you, the listener, who wants to actually understand the systems running our world, without grounding in all that policy jargon.
Mm-hmm. And today's source material is really something else. It's a powerful essay by Dr. Frank Opelka.
Yeah, he's a surgeon who hit that exact breaking point we just talked about. He got so tired of watching the system essentially bankrupt the patients he was saving that he actually left the operating room entirely.
Right, he became a health policy expert.
And our mission today is to explore his roadmap out of what he calls the American cash register economy of healthcare.
And what makes this roadmap so compelling, I think, is that it completely bypasses the usual partisan shouting match we always see on the news.
Oh, absolutely.
It offers a highly structured, systemic analysis of how to restructure the incentives of the medical system. And the core premise is incredibly practical. We do not need to burn the system down.
Thank goodness, because imagine Congress trying to rebuild a multi-trillion-dollar industry overnight.
It's a terrifying thought.
It really is. A sudden, massive legislative overhaul would simply collapse under its own weight. So instead, Dr. Opelka argues that we need to essentially land the plane we are already flying.
Right. We can build a new social contract by scaling frameworks that actually already exist in the background.
But before we can talk about a safe landing, we kind of have to talk about why the current flight is so incredibly turbulent.
Yeah, and to do that, we have to map the current state of U.S. healthcare. And the most clarifying thing to understand here is that the United States does not actually have one single healthcare system.
Which is wild to think about.
It is. Globally, there are basically four models of healthcare funding and delivery. The U.S. runs all four of them simultaneously, just sort of stapled together.
Okay, let's unpack this.
Yeah.
Because this is where the sheer scale of the chaos becomes really obvious. It's like we are flying a massive four-engine airplane, but every single engine is taking commands from a completely different pilot.
That is a great way to look at it.
So let's look at those engines. First, you have the beverage model. This is where the government actually owns the hospitals and employs the doctors.
Right, making it free at the point of service. You see this in places like the UK or Spain.
And our American equivalent is the Veterans Health Administration, the VHA.
Exactly. Then you have the single-payer model. In this engine, the government runs the insurance pool, but the hospitals and doctors are totally private.
Like in Canada.
Like in Canada, yeah. And in the U.S., this is exactly what Medicare is. It's public insurance paying for private delivery.
Got it. So engine number 3 is the Bismarck model. This one relies on shared funding between employers and workers to pay for private insurance plans.
Think Germany or France for that one.
And our equivalent is employer-sponsored insurance,
Mm-hmm.
basically what most working Americans have.
Right. And finally, engine number 4 is the out-of-pocket model.
Just direct cash payment before you get care.
Yeah, which is the reality in many developing nations. But in the U.S., this represents the roughly 28 million Americans who were totally uninsured in 2025.
Wow.
What's fascinating here is that the massive waste in American healthcare isn't a bug or a glitch. The waste is the literal friction created at the seam where these four completely different models grind against one another.
Inside a single patient's care journey.
Exactly. You have four different sets of incentives actively fighting each other for dominance.
And it's getting worse, right? Because the Congressional Budget Office projects that recent federal spending cuts will add roughly 10 million more uninsured people over the next decade.
Yeah, so we are looking at nearly 40 million people being forced into that out-of-pocket engine.
And this friction is exactly why you, the listener, receive those baffling explanation of benefits that explain absolutely nothing. You might have an employer-sponsored plan paying a private hospital, but your anesthesiologist bills out of pocket because they are technically out of network.
Right, and the billing codes they use are dictated by Medicare standards. It's a mess. You end up paying for a massive administrative army whose only job is to just translate between these four conflicting languages.
So we know the plane is essentially tearing itself apart midair. That means we need to identify a very specific destination. Like, what does a functional U.S. healthcare system actually look like, assuming we rule out nationalizing all the hospitals into some British-style system?
Well, Dr. Opelka calls this destination the landing zone. It's a hybrid model, specifically single-stream financing paired with regulated private delivery.
Okay, let's translate that for everyone. On the financing side, you create one public funding stream. This would combine Medicare, Medicaid, and subsidized employer pools into a single vehicle.
And that vehicle sets universal base rates. By establishing universal base rates, you essentially eliminate the thousands of confusing, disparate fee schedules.
The ones that currently exist purely to confuse the market and maximize billing.
Exactly. But crucial to this plan, the actual delivery of the care remains entirely private. You would have competing, nonprofit, accountable care ecosystems.
Accountable care ecosystems.
Right.
There's basically regional networks of doctors and hospitals all working together.
Yes, and the payment mechanics change completely. This marks the absolute end of fee-for-service.
So no more getting billed for every individual bandage or like every single minute of a doctor's time?
Right, none of that. Instead, the system pays these regional networks in two ways. First, a fixed annual budget per patient. They call this a per member per month payment, or PMPM.
And that covers general health and primary care.
Right. And second, they get bundled payments for acute events, meaning a single flat rate for, say, a joint replacement or an entire round of cancer care.
Okay, let me push back on this on behalf of anyone listening who has ever dealt with a nightmare insurance denial. Because if hospitals get a fixed capitated budget per patient every month, won't they just cheap out?
That's the immediate fear, yeah.
Right. Like what they deny necessary care just to keep whatever cash is left over at the end of the year.
And that concern is exactly why this model requires a total perspective shift. Under this capitated model, the whole game changes. The regional ecosystem only thrives financially if it keeps the patient healthy over the long term through prevention.
Oh, I see.
Think about it. If they cheap out and deny you a necessary screening today, you end up in their emergency room with a catastrophic issue a year later.
Which costs the ecosystem far more than the screening would have.
Exactly. We stop paying for medical activity, which is just volume, and we start paying for actual health outcomes.
It fundamentally aligns the hospital's financial incentive with your physical well-being. So the destination is clear value over volume.
Yes.
But, identifying the landing strip doesn't magically put the massive plane on the ground. How do we transition a multi-trillion-dollar industry without causing a massive shock to the economy?
Well, the most important detail here is that the testing ground for this transition already exists. It lives right now inside the CMS Innovation Center.
Which is a federal hub dedicated to testing new payment models.
Exactly. We don't need to invent new machinery from scratch. We just need to take those voluntary pilots and scale them into a mandatory national architecture. And Dr. Opelka maps this out as a 3-phase, 10-year flight plan.
Okay, so phase 1. That covers years 1 through 4. And the goal here is to just rationalize the payment engine. You mandate standard cross-payer data models for things like prior authorization and billing.
Which forces every single commercial insurer onto a single administrative portal.
So nobody loses their job in year 1, but it immediately collapses the massive overhead of all that hodgepodge administration.
Right. And during the same window, you shift Medicare Advantage and Managed Medicaid into 100% two-sided risk.
Two-sided risk. That is a vital concept to grasp. It means providers are finally accountable for losses, not just the gains.
Exactly. If a clinic's patients stay healthy and the care costs remain low, the clinic shares in those financial savings. But if the costs explode because of poor preventative care, the clinic is on the hook for the losses.
Suddenly keeping you healthy is a literal financial necessity.
Yep. So once that administrative mess is cleaned up, how do we actually change the way care is delivered? That brings us to phase 2, which covers years 5 through 8.
The structural integration phase.
Right. You take primary care payment and you fully decouple it from the face-to-face visit. Instead, you move to that monthly management fee we discussed.
And decoupling the payment from the visit is kind of revolutionary, because it means we can finally fund the care orchestration teams.
Oh, absolutely. The social workers, the pharmacists, patient navigators. Fee-for-service has always starved these roles.
Because you literally cannot bill a standard insurance code for a pharmacist spending 20 minutes explaining a complex medication schedule to a confused patient.
You really can't. But phase 2 provides the actual budget for that pharmacist. It also anchors specialty care to mandatory bundled episodes that are tied directly to that primary care relationship.
Okay, here's where it gets really interesting. Phase 3, years 9 and 10, the consolidation phase. This calls for absorbing commercial insurance risk pools into a state-regulated public option marketplace.
Right.
And traditional insurers are basically converted into administrative services-only contractors. Now, looking at this timeline, absorbing all commercial risk pools into a public marketplace sounds exactly like the burn-it-down overhaul we were promised we'd avoid.
It does sound like that, yeah.
How does that not completely collapse the insurance market?
If we connect this to the bigger picture, you'll see the magic is entirely in the sequencing. I mean, if you tried to execute phase 3 tomorrow, the system absolutely would break.
Sure.
But by year 9, the financing rails, the universal data standards, and those risk-bearing regional networks have already been built and tested over 8 long years.
Ah, so the foundation is solid by then.
Exactly. We aren't asking major insurers to simply vanish overnight. We're asking them to do what they're actually incredibly good at processing claims, but to do it inside a public financing vehicle.
So that's what administrative services only means. They just handle the back-end paperwork.
Yes, it's a conversion, not a demolition.
Okay, so we have mapped out the flight path, but there's a massive operational hurdle here. You cannot fly a modern digital airplane with analog dials. The literal tools that doctors use have to fundamentally change.
Which brings us to the informatics gap.
Right, because right now, electronic health records, or EHRs, are essentially just glorified cash registers. They were built to maximize billing codes, not to actually heal patients.
Yeah, and if the landing zone is going to function at all, that informatics layer has to shift from documenting care to actually delivering it. So Dr. Opelka introduces what he calls the 3 proofs of healthcare value.
And this relies heavily on things called open FHIR APIs, which, without getting too technical, basically act as a universal translator.
Right. They allow different hospital software systems to securely talk to each other in real time.
So the first of these proofs is proof of service. Right now, doctors are basically forced to act like data clerks, hunting through messy PDFs and unstructured notes just to figure out your medical history.
It's a huge waste of time. Proof of service means the systems automatically synthesize a patient's multi-facility history into real-time insight the absolute second the doctor opens the chart.
Amazing. And the second is proof of safety. Currently, risk scoring is retrospective and based on past claims, which is incredibly slow and, frankly, easy for hospitals to game.
Yeah, we need algorithmic real-time risk adjustment using clinical markers and social determinants of health, or SDOH.
Which are factors like a patient's access to transportation or healthy food, right?
Exactly. Factoring those in ensures that a care team who takes on a highly complex, low-income patient receives a proportionally higher capitated budget. The system has to financially reward doctors for taking the hard cases, rather than incentivizing them to dump complex patients just to protect their margins.
That makes so much sense. And the third is proof of benefit. We have to start capturing patient-reported outcome measures. I think about it like this. Current EHRs are kind of like a grocery store checkout scanner.
Okay.
That scanner cares immensely about the exact barcode and the precise price of your apple so it can charge you. But the scanner doesn't care at all if eating that apple actually cured your scurvy.
That is a perfect analogy. Proof of benefit completely changes that software mindset. It's no longer about, did the doctor check the box that the surgery happened? It's about, did the knee replacement actually let the patient walk their dog again?
Right.
That shift transforms the computer from a billing mechanism into a dynamic tool for achieving the patient's stated life goals.
For you listening, think about how frustrating it is to sit in an exam room and have to verbally repeat your entire medical history, your allergies, your past surgeries to 5 different specialists in the exact same network.
Just because their computers literally do not talk to each other.
Exactly. Upgrading the software is what makes the whole 10-year flight plan possible.
But, you know, upgrading the software and changing billing codes sounds great in a vacuum. In the real world, plans on paper don't survive without dealing with political and market forces.
Very true.
You are threatening a multi-billion-dollar billing industry. So there are 3 systemic pressures that will ultimately decide if this framework survives contact with reality.
Okay, so the first force is the political shock absorber. Because we are talking about a massive labor transition here. Healthcare administration currently employs millions of Americans in billing, coding, and denial management.
Yeah, and if we suddenly shift to a highly efficient single-stream system, we trigger a massive white-collar unemployment cliff.
And political reality is what kills reform. So the roadmap has to actively retrain those insurance workers. They need to be transitioned into the care navigators, the community health workers, and the informatics specialists for that expanding primary care infrastructure we talked about in phase 2.
Right. The trillion-dollar administrative economy needs a highly coordinated, safe off-ramp.
The second force is the antitrust trap. Because as hospitals merge into these accountable care ecosystems, they're going to gain enormous monopoly power in their regions.
Oh, absolutely. Without a referee, a newly merged super hospital could just double the price of an MRI because you literally have nowhere else to go.
So what's the fix?
The proven fix for this is a state-level global budgeting commission. This commission steps in as that referee, telling the hospital exactly what their total revenue cap is for the year based on the community's needs.
Oh, wow. Does that actually work?
It does. Maryland actually ran this exact model for a decade, and as of 2026, it is scaling to additional states via a federal testing model called CMS Ahead.
So we already have a working template to prevent monopolies from gouging the system.
Yeah.
We just have to mandate it alongside the hospital consolidation.
Exactly. Which brings us to the third force, the unlikely champion. The catalyst for this massive change is not going to be Washington, D.C., and it certainly won't be the legacy hospital systems or the insurers who are profiting off the current fragmentation.
No, the champion is going to be the self-insured jumbo employer. Giant corporations buy healthcare directly for their workers in the billions, and they are so tired of watching systemic waste eat their profit margins alive. So what does this all mean?
It means that when a coalition of major employers decides to bypass traditional insurers entirely, they will demand direct capitated contracts with these new regional networks.
Yeah, they have the buying power to force the market to follow their lead.
Exactly. The government's role simply becomes codifying the path that private buyers already paved. The real revolution starts in corporate HR departments that are just tired of being robbed.
There is one more piece to this puzzle, though. The proving ground. The pilot. And it's basically hiding in plain sight. Rural America.
Right.
Fee-for-service has already completely failed there. Hospitals are closing, service lines are vanishing, and whole counties are left without a single delivery room.
This raises an important question. Why start in the hardest, most resource-deprived environment?
Well, because the old machine is already dismantled there. Right?
Yes. There's far less resistance and immense political will to try something genuinely new. You never let a good crisis go to waste.
Right.
If you can get this model right in rural America, building well-orchestrated primary care and regionalizing those critical acute episodes, you don't just save rural healthcare. You build the exact template that the rest of the country will eventually adopt.
Let's bring this all together. The U.S. healthcare system right now is a massive airplane burning fuel with 4 engines actively fighting each other and nobody steadily holding the yoke.
A scary flight.
Truly. But as Dr. Opelka lays out, the destination isn't a fantasy. We don't have to invent a new social contract from scratch. It is a landing we simply have to choose to make. The testing frameworks already exist in the Innovation Center.
The jumbo employers are frustrated enough to move.
And the crisis in rural America is handing us the perfect place to start.
The literal tools are there. We just have to strategically sequence the approach.
So for you, the listener, you now have a master key. The next time you see a headline about a massive hospital merger or a debate about Medicare Advantage, or you receive one of those baffling multi-page medical bills, you understand the underlying friction causing it. You know exactly why the gears are grinding.
Yeah, you understand that you are caught at the seam of 4 different global models operating all at once, and why the shift to paying for value over volume is really the only way out.
I want to leave you with one final thought to mull over, something that builds on this entire roadmap. If jumbo employers in rural communities successfully bypass traditional insurance to create these highly efficient, value-based regional networks, how long will it take for everyday citizens to demand that same direct access?
That's a great point.
Right. If you are a gig worker or a small business owner and you see the corporate employees getting seamless, capitated care that actually focuses on keeping them healthy, will you accept the old broken fee-for-service model?
Probably not.
Could this corporate and rural pilot accidentally spark a grassroots, consumer-led revolt against the remaining legacy insurers that even this 10-year plan didn't anticipate?
That is the ultimate ripple effect. Once people see that the plane can actually land smoothly, they simply won't accept the turbulence anymore.
They really won't. And maybe, just maybe, we can finally bring the extreme precision and focus of the surgical operating room to the way we actually pay for it. Thank you for joining us on this deep dive.